Finally, I would like to talk a little bit about the barriers to biomarker testing. As I mentioned in the few slides earlier, that biomarker testing is sort of now the current standard of care, and every patient that we see with non-small cell lung cancer, specifically with advanced stages, but also now more and more in the earlier stage setting, needs biomarker testing. We need to identify genetic alterations. We need to identify PD-L1 status to help us make decisions for treatment. However, having said that, there are barriers to such testing. There are challenges, and unfortunately, biomarker testing is not universally applied as it should be. And so now I want to just talk about some of the barriers and challenges that we face in biomarker testing. This snippet is from an excellent paper by Sadik and colleagues that was published last year. Essentially, they studied patients with newly diagnosed advanced non-small cell lung cancer who were potentially eligible for targeted therapy, about 1,000 patients, and they found that only 356 of these patients were actually treated with targeted therapy. So really, there are a lot of practice gaps that have been identified, which are prohibiting us or preventing us from truly applying precision medicine or precision oncology as we would like. I think some of the biggest barriers here is actually ordering and obtaining biomarker testing. As you see, about 18% of patients did not have this as standard of care in this particular study. And the other issue or barrier is the treatment decision making, and actually for the patients where we've identified genetic drivers or immunotherapy-based biomarkers, to actually apply those results in treatment decision-making. Again, here you see about 30% of patients did not receive treatments as per their biomarker testing. And some of the issues in terms of ordering the test, physicians not ordering the testing, lack of awareness of the current guidelines for non-small cell lung cancer testing, as well as insurance challenges are what truly prohibit ordering of the biomarker test. And in terms of treatment decision-making, again, targeted treatments not being selected despite positive test result or report indicating no therapy or alternative were the major reasons for why this practice gaps occurred. There's more data and evidence showing that the adoption of biomarker testing is substandard. This is a sort of slightly older study now, a retrospective study from 2016 to 2020 among the community oncology sites, again showing there is inadequate testing in community oncology setting. On this right panel here, if we look at the numbers, here this particular study only included the 5 of the biomarkers that we discussed. And again, among these 5, if you look at the patients, the number of patients who actually had biomarkers tested before initiation of first line, really sort of falling between 25 to 55%. And again, this really should be 100% is what the aim is and the goal is. And again, of these patients, biomarker-directed treatment, as you see here, also varied widely among the different biomarkers that were identified, and again, identifying the same practice gap of actually applying the results of our testing paradigm. Solutions to this may be integrating these testing as reminders in our electronic medical records. This has been studied. There is this EMR-based nudge intervention workflow, which was developed by our colleagues at University of Pennsylvania, where every time the care team saw a patient who had newly diagnosed treatment-naive non-small cell lung cancer, there would be a trigger to the provider team to really identify whether a plasma-based next-generation sequencing biomarker testing assay was indicated, and if it was indicated, was it ordered, or it would help an auto-generated NGS order, which actually did increase the amount of biomarker testing. On the right panel here, they look, are the results from this study. They looked at 526 patients, 381 in the pre-intervention and 145 in the post-intervention cohort. And essentially with this sort of nudge, as well as the email-based reflex alert program workflows, they were able to post-intervention, there was a significant increase in ordering of tissue as well as plasma next-generation sequencing, comprehensive next-generation sequencing, as well as the next-generation sequencing prior to the first-line therapy in the post-intervention setting. So this potentially could serve as a solution to make sure that we are ordering biomarker testing when it is truly indicated for our patients, and hopefully we're not missing as many as we saw in some of the earlier studies.